Apologies for the Liberty Mutual ad that came up quicker than I could stop the screen share. Um, I wanted to start the meeting with a little generational mashup for those of us that are looking for some connection over American folk music. So that was a Crosby, Stills, Nash and Young song that was covered by Hanson. So we're spreading three generations there, listening to them. And the lyrics didn't quite come up the way I thought they were, so I will put those in the chat later for folks who want to take a second to read those. Uh, Welcome to Public Health Modernization Chats. This is our March session. I'm Heather Redman. I use she, her pronouns, and I'm the Strategic Initiatives Partnerships Coordinator within the Public Health Division at OHA. We already have our presenters here and ready to go, so I want to keep my intro short. But you all know the drill. If you'd like to pop in the chat and introduce yourself, name, pronouns if you wish to share, where are you joining from, are you doing the work of public health out in your communities? And if you want to, share something that you're looking forward to now that we will have longer days after the weekend. I personally have mixed feelings about daylight savings time. It makes me grumpy and sleepy. But yeah, we're supposed to have the sun longer into the evening. So name, where are you from? Where do you work? And what's something that you're looking forward to now that the days are getting longer? While you all are introducing yourselves, I am going to pass it over to our presenters. So please, Thomas and Kasuma, take it away.
Thank you, Heather. Thanks for you all for being here today. My name is Kasuma Matamala. I use she, her pronouns. I'm a public health systems and services researcher in program design and evaluation services, or PDES. Presenting with me today is Thomas Packabush. He's our research analyst, and PDES is an interagency research and evaluation unit housed in the Oregon Health Authority Public Health Division Director's Office, as well as Multnomah County Public Health Department. And today, Thomas and I are looking forward to sharing with you some of the results from the Public Health Modernization investment dollars. And we're going to give you a high-level overview. I also want to acknowledge some of our other evaluation team members. We were grateful to have the contributions of two former AmeriCorps Vistas, Sandy Rice and Kelsey Young, who participated in this work, and Doris Cordova, who's part of our PDS team. So Thomas will go to our first slide. We have a lot to cover today in this time, so we are going to be going through quite a bit of information. There'll be more in the report, but please tell us to slow down. We're going to go slower since we don't have as much as it's more high level today, but the report that's coming out this spring will be more detailed information. All right, so for today, we're going to share with you some of our evaluation process, the areas of focus, those evaluation domains, and the corresponding questions that were co-created, and share who was involved in that process. Some high-level results on each of these areas of focus for the evaluation, one on these organizational structures, which I'll share more about. And then the second domain or area of focus for the evaluation was the implementation of accountability metrics. We'll share some participant recommendations, and then hopefully have some time for an activity and some discussion at the end so we can get your feedback. All right. We'll go to the first slide. As we share these results with you today, knowing that you'll see more results in a report coming out, we'd like you to think about what are you hearing and does it resonate with you and what does not. And we'll have some time for discussion at the end related to these questions. And then what actions would you really like to see come out of this work? Okay. So I'm pleased to share that this evaluation was co-created by two groups that we had guiding this work. One was an evaluation working group comprised of both state and local health department staff. This group has been meeting almost every other week, give and take some times in between when we were working on analysis, every other week since the beginning of the biennium, so around July of 2023. We also have an evaluation technical panel that is not only comprised of state and local governmental public health staff, but also representatives from CBOs who've been funded through this work, as well as a tribal representative and the Public Health Advisory Board chair. And the purpose of both of these groups is to, and that technical panel met every couple months. So it's a little bit more high level compared to the working group that was more in the weeds in the work. The purpose of these groups was similar, really to assist the Oregon Health Authority Public Health Division to co-create an evaluation of the 23 to 25 legislative modernization funding investments. And that work included helping us develop those core evaluation areas or domains that I shared earlier, and the questions that we'll share in a minute, the methodology of how we gathered the information, really helping us to interpret and analyze the data as we were getting it to make us sure that we were understanding this correctly, and then helping us review different report writing, whether that be informal reporting or presentations that we've been giving. We'll be using the PHM acronym throughout. That's going to be referring to public health modernization. And for those of you know, just that modernization funding for CBOs goes through the health equity grant. So I just wanted to make sure that that was clear as well. And we are very grateful to both of these groups for their time, guidance, and contributions to this work. Okay, we'll go to the next slide. So as I mentioned earlier, our two evaluation areas of focus, or the domains and questions, are very much interconnected, and they inform one another. One is focused on the system-wide organizational structures, and that is these public health organizational structures as defined by Turnock et al. In 2001 are really these structures that are around informational resources like guidance documents, financial resources like the impact of funding, and human resources like our workforce. So how does the system-wide structure around PHM facilitate and prevent progress and the subsequent impact of the investment? So those are really the inputs into this process of modernization. And then some of the outputs and outcomes coming from that are the implementation of these accountability metrics, which Thomas is going to share a little bit more about with you coming forward. But that domain or area of interest was really focused on what's preventing and facilitating progress on the accountability metrics, the process measures, and the corresponding activities in different parts of the state through local public health authorities and through OHA. And how is work towards the accountability metrics advancing health equity? The second domain is really right now has been focused on local and state public health authorities work, and in the future we'll be incorporating more of our other partners' work here as well. Okay. So going into this first area of focus related to these organizational structures, we'll go into the methods, which is the next slide, and share with you that we did 8 virtual focus groups and 3 key informant interviews between May and September of 2024. That included 4 local public health authority focus groups with administrators by each of the 4 different size bands throughout the state. 2 focus groups with OHA staff in the public health division. One was program staff that are engaged in modernization work, and then another one with the director's office staff in the public health division. 1 focus group with the Public Health Advisory Board members, and 1 focus group with our community-based partners, our organization partners. When we realized that our participants in some of the CBO focus group were primarily in the I-5 corridor, we did additional 3 key informant interviews to get broader representation from CBOs in different parts of the state. You can see there the length of the focus groups and the interviews, and I'm happy to share more details later if you need about coding and reviewing of all transcripts. We also used a workforce survey that was done for our local public health authorities that captured some of the workforce dynamics for public health modernization funding directly to LPHAs, as well as the regional public health funding for local public health agencies. Okay, I'm going to go into I wanted to share the context really broadly in which this work is happening. So our goal with this evaluation is really to be able to use these findings to advance our public health systems work about what's working well and what we can do to kind of to improve and understand what can be improved upon. And so the context in which this work is happening is really important. Throughout this last 2 years, we've seen, as with the last 2 years prior to that, a lot of changes in public health leadership throughout the state, both at the local level and at the state level. There continues to be an overextended workforce in our public health system, and just recognition of how our governmental public health system is structured. In Oregon, we're a decentralized structure, and also realizing that public health undergoes crisis funding, as many of you know. There are cycles of funding and defunding public health, and that is something to consider as you're thinking about this, what we're about to share with you. I also want to recognize that this data, as I mentioned in the earlier slide, was collected before the election, the presidential election, and everything that has happened since then. So just a reminder that this data was collected well before November of 2024. Okay. I'm going to share some high-level findings from this first domain related to public health modernization. So our participants, across all the participants, that is our local public health authorities, our OHA, Public Health Division program staff, our CBOs, and our FAB representatives, all mentioned that there was this thinking about public health modernization. Is it a funding stream? We heard that this is how we get our funds across, versus others who also thought, well, no, it's really a broader change improvement model. So we heard both of these things about how public health modernization is articulated and understood. There seemed to be a need for clarity on this concept across the organizations and what success really does look like. And that lack of clarity and need for greater understanding, regardless of one's tenure in their organization, whether they had been around since the inception of public health modernization at a local level, or whether they are new to that concept, there still was needed for clarity. We heard a limited mention of guidance documents, including the modernization manual, and noting that the modernization manual had some challenges to use and needed some updating. Other high-level findings were there was an appreciation for the flexible funding that modernization allowed. Being able to tailor to one's local needs was really important. We heard a growth in capacity of the workforce across both state and local and CBO partners, but yet ongoing workforce needs. We also heard that it's hard to align sometimes when we're not knowing what each other is working on. So the recognition of existing silos and needs to coordinate. And we also heard varied voice in decision making, with some feeling like their voices were being well heard and others not as nearly as much. So now I'm going to turn it over to Thomas.
Yes, thank you, Kazuma. I haven't introduced myself yet, but Kazuma did it for me. I'm Thomas McAbush. I use he, him pronouns, and I am a research analyst with PDES. So Kazuma just went over some of the high-level themes that we heard, and I'm going to dive a little bit deeper into some of them. And again, these themes were present across everyone that participated in our focus groups, LPHAs, Public Health Division, CBOs, and FAB. So starting with this concept of public health modernization and how it's viewed, as Kazuma mentioned, we heard it as both a funding stream and as a change improvement model. And so a quote that we heard as an example of modernization being viewed as a funding stream is, "My understanding is that this is all part of how we advocate for the funds that we need today, whether that be for the state, whether that be for the local public health, whether that be for our community-based organizations. It's all coming in this package of modernization." And as a change improvement model, we heard from a focus group participant that I don't think that I fully embraced at the time that public health modernization is truly a continuous quality improvement effort, and that over time, if we're doing our work right, how we are doing it is going to fundamentally change. So, building off of those two views of public health modernization, our next theme is just a need for more clarity across organizations on what modernization is and what success looks like. So, some quotes that we heard from focus group participants relative to this. Modernization is just a word that gets tossed around a lot, and I've not encountered too many people who really have a clear ability to explain it. I don't really know what success looks like anymore when it comes to public health modernization. And I think there's an opportunity with a new OHA director, a new public health director, to have public health modernization defined, to define a role, and define how we can best advise them. I would like to know really, I would like to really know exactly what OHA wants. What is the actual question they want us to answer for them, and how is that answer going to be used? So another theme that we heard was the need for alignment and coordination between partners involved in this public health modernization work. So participants shared that it's hard to align with each other when you're not familiar with what others are doing, and that there's a general need for more coordination between each other. So some of the quotes we heard about this, I read about all these plans that folks had hoped to do if they got funded, and I don't really know what they're doing. I think we really need to look beyond the voluntary sharing of knowledge, information, and resources and look into leveraging existing resources in a contractual way and or a legislative way that we're held accountable to work with one another. So we also asked our focus group participants how they felt their voice in the public health modernization decision-making processes were heard. And we heard that for LPHAs, voice varies by tenure and position in their organization. Some LPHA participants felt that they had more voice locally than they do statewide. We had some CBO participants express more of a voice with OHA and felt more heard than our other focus group participants. And in general, we heard that just power sharing is difficult. So a couple quotes about that. I think that's a gap to really feel like programs or sections have sort of an ongoing voice in how things are unfolding. And I've been really impressed on what a voice my little CBO in this region has had with big OHA. So the last thing that I'll share some quotes about is communications. And communication is really at the core of many of the themes that we heard, alignment, voice, and coordination. So some communication related quotes that we heard were, I am reticent to say I fully understand what their being OHA, vision is. I think that's part of what the problem is. I don't feel like that's communicated well. And I just think that there's not a clear communication pathway at this point or strategy, and that worries me going into the next legislative session. So to wrap up those themes, again, very high level, we'll put them in the context of structural facilitators and challenges to public health modernization. So some facilitators included the ability to tailor modernization funding to local needs, increase staffing capacity through modernization funding, and the ability to build more collaborations at a local level. And some of the challenges that we heard were a need for clarity of the modernization concept, purpose, and vision, uncertainty around a sustainable plan, need for stronger alignment, coordination, and communication within and between partners, feelings of voices not being heard by some, and ongoing capacity needs, particularly at small rural LPHAs and CBOs. And lastly, a need for guidance documents and improved communication of the guidance documents that already exist. And I'll pass it back to Kazuma to talk about some participant recommendations that we heard.
Thanks, Thomas. So it should be noted that we didn't ask specifically for their recommendations, but these came up from participants in the course of the conversations. And so these are individual recommendations that were suggested by participants as related to public health modernization. So one was having some OHA Public Health Division guidance on a shared vision informed by the Public Health Division programs, local public health authorities, the Public Health Advisory Board, and CBOs that included clear pathways and feedback loops on how to best advise leadership. Understanding who can do what well and greater need for role clarity, and clarity between modernization as a funding stream and or a broader change or QI initiative, and really to communicate that vision internally and externally to partners and have further conversation about access to clinical and preventive services as part of the foundational public health programs. I also want to note that we have in our evaluation report some evaluation team recommendations that build off of these participant recommendations that we're not sharing with you today, but will be in the report. We'll go to the next slide. Related to guidance documents and the modernization manual and work plan, some participant recommendations included the need for guidance documents or greater communication of the ones that currently exist, including the modernization manual, to perhaps include that in the Public Health Advisory Board member training, and to revise and review the manual at regular frequency by staff in the field. Related to the work plan, just increasing awareness and a mechanism to see each other's funded work and strengthen the mechanisms to hold each other accountable in these spaces. We also heard from participants the need to reduce administrative burden of reporting and to possibly consider some joint work plans. Overall, for this evaluation domain area, we generally heard the needs for greater clarity in terms of modernization, whether it's stemming from overall communication related to limited use of a manual, limited mention of some guidance documents, funding stream or change management, how it's seen, limited workforce capacity, and varied voice in decision making, and just really the existing silos that exist that all contribute to that need for greater clarity, and needs for greater communication among them. So that's an overall for this first domain area. And now I'm going to turn it over to Thomas, who's going to talk about the second evaluation domain and corresponding questions. Thomas?
Thank you. So, as you may recall from the beginning of this presentation, this domain has two evaluation questions that we are trying to answer. So this section is going to focus on that first question of what facilitates and prevents progress on Oregon's public health accountability metrics, process measures, and corresponding activities in different parts of the state through LPHAs and OHA. I'll note that the process measures for OHA and for LPHAs are very clearly defined. And although there are not clear specific measures for CBOs, all of your work contributes to advancements in health. Everyone in this modernization and accountability metrics work has a role in making improvements on the metrics, and it takes all of us working together for those improvements to come to fruition. So this domain is focusing on the accountability metrics and the actions taken towards them, so we should probably define what those are. There are three overarching accountability metrics priority areas. One is to protect people from preventable disease by increasing vaccination rates. And this is being looked at in the context of influenza vaccination rates for adults ages 65 plus and 2-year-old vaccination rates. The second is to increase community resilience for climate impacts on health, looked at in the context of extreme heat and wildfire smoke. And the health indicators that are looked at in this section are urgent care visits, emergency department visits, and hospitalizations due to heat or respiratory complications, as well as heat deaths. And the third and final priority area is to reduce the spread of syphilis and prevent congenital syphilis. And those health outcome indicators in this area are the rate of congenital syphilis, the rate of syphilis among people who can become pregnant, and the rate of primary and secondary syphilis. So those are the accountability metrics priority areas and their indicators. So this domain is focused on the implementation of the metrics in these three areas. So we have multiple data sources that we used for this domain. Those include results from 4 virtual focus groups held in August and September of last year. These are different from the focus groups you just heard quotes from. We conducted 3 of these focus groups with LPHA program managers and admin by the accountability metrics priority areas, as well as 1 focus group with public health division program staff across all of the priority areas. Each focus group was an hour and a half, and our team coded and reviewed all of those transcripts. We also used data from the LPHA Accountability Metrics Process Measures Survey conducted last summer, in which LPHA selected the process measures that they will be working towards and the associated activities they are doing towards those measures and metrics. We used data from OHA's Accountability Metrics Process Measures reporting also done this past summer. And lastly, our evaluation team conducted 2 case studies on Lincoln and Multnomah counties to take a deeper dive into the accountability metrics work of those counties. Those case studies we're not going to talk about here today, but they are going to be available as standalone documents in the coming months. So those are our data sources for what we'll be sharing moving forward in this presentation. So The things that I'm going to share are very high level summary of our findings. There's a lot of information in this domain. And again, we're trying to answer the question of what facilitates and prevents progress on these accountability metrics and corresponding activities. So we identified some facilitators by organization type. And again, remember this domain really focused on LPHAs and the public health division. So by LPHA, some of the facilitators that we heard were having designated modernization funding for accountability metrics work, identifying priority populations through the use of data. The LPHA is prioritizing the accountability metrics program areas in their work, and where possible, connecting it back to larger county priorities, such as strategic plans and such. At the Public Health Division, on the state side, we heard that aligning the metrics with other required strategies where possible is a facilitator, such as any federal strategies and funding that they may receive, as well as having a skilled workforce with great expertise in these areas. And across both groups, we heard that partnerships with local CBOs and other LPHAs is really a clear facilitator. In terms of challenges, we heard from LPHAs having a lack of available data at smaller geographic areas can make things a little bit challenging to identify populations that are in need of serving. Limited expertise in assessment and surveillance and outreach at smaller rural LPHAs, insufficient supports and resources to engage in policy-related work. And sometimes county-wide priorities may not advance or support LPHA priorities. On the state side, we heard that there's just a lot of competing state priorities. A direct quote that we have, and I apologize for saying priority so many times, is it's often challenging to figure out which priority is the priority of the priorities. Um, and then between both groups at LPHAs and Public Health Division, we heard poor data quality could be an issue, such as underrepresentation of certain communities or having missing data, a need for greater workforce capacity, a need for coordination and clarity on who's doing what in this space, a need for continued funding to support the accountability metrics, and an uncertainty about continued statewide support for the accountability metrics work. So I'll pass it back to Kazuma for some recommendations.
So similar to the previous domain, we heard from participants what they recommended. And so that's what I'm going to share with you right now. Related to data, we heard about the need for additional training on accessing data, addressing gaps in the data that exist, specifically in rural areas. For the workforce, we heard within the Public Health Division, additional investment in the state workforce out of the Director's Office for Modernization, as well as ensuring public health programs are appropriately staffed to do the accountability metrics related work. In terms of policy, we heard about the need for state-supported guidance when sometimes county-wide priorities may not necessarily align with advancing the metrics. An increased need for policy-related work, capacity for it, whether it's funding for that, the workforce to do policy-related work, or state-level capacity to look at external funding opportunities to do this type of work. In terms of strategies of coordination to do the accountability metrics, we heard overall from all participants that just the need to stop, regroup, and take stock of what has happened to this point for public health modernization and the accountability metrics, to invite people to conversations that affect them, and have the space that connects the Public Health Division programs, LPHAs, and CBOs engaged in accountability metrics work. And I think this reflects one of the comments I saw earlier about a space for having that dialogue, and that identifies with the overlap with that for earlier domain. Identify roles specifically for the Director's Office and state programs, and align metrics to federally required strategies to reduce the burden on our workforce, and create a visualization about how all the state-specific priorities really fit together and tell the story. Okay, Thomas, I'm going to turn it back over to you for the second question.
Yep, thank you. So this next part that I'm going to share about is focusing on that second evaluation question in this second domain. How is the work towards the accountability metrics advancing health equity? So there's some guidance documents that our evaluation team has used to help identify the activities that are helping to advance health equity. Those documents are the Public Health Modernization Manual, OHA Strategic Plan, the CDC's Equity Framework, and the Bay Area Regional Health Inequities Initiative Framework, or BARHI framework, for reducing health inequities, which is pictured very tiny in the bottom right corner. I know it's hard to see. Um, but we acknowledge that health inequities exist because of upstream social and institutional factors, and that there's opportunities to intervene and address those health inequities both upstream and downstream. So the activities that we highlight in this section and in the full report, uh, we use these documents as our reference points and just demonstrate some of the ways in which our public health system is working to address health inequities. I also want to call out OHA's goal of eliminating health inequities in the state by 2030, which ensures that all people in Oregon can reach their full health potential and well-being and do not face disadvantages due to their race, ethnicity, language, disability, immigration status, age, gender, gender identity, sexual orientation, geography, or social class. So you saw this slide earlier. These are our three accountability metrics priority areas: protecting people from preventable diseases by increasing vaccination rates, increasing community resilience for climate impacts on health, and reducing the spread of syphilis and preventing congenital syphilis. Given our limited time to speak with you today, we're just going to share some high-level actions being taken by LPHAs and the Public Health Division in the immunizations priority area. Everything we'll share is very high level. There's some really great quantitative and qualitative data surrounding these activities that LPHAs have reported on in all three priority areas, but we just don't have the time to share all of it today. Um, all three of these areas are going to be included in detail in the final report, so there will be a chance to see it. So looking at the immunizations priority area, we are going to focus on LPHAs first. So LPHAs were asked what priority populations they were able to identify through the use of data to address disparities in immunization rates. And for those prioritizing influenza immunizations for adults ages 65 plus and those prioritizing 2-year-old immunizations, the top priority populations that they identified were in these general categories of racial and ethnic groups and geography, such as certain zip codes or rural parts of a county that may be experiencing disparities. A sample of some of the actions that LPHAs are taking to address disparities in immunizations include mobile vaccination campaigns, hosting vaccine clinics at long-term care facilities or out in the community, and working with partners to develop culturally specific communications and culturally appropriate education materials. And as I said before, there's some really detailed data and examples of all of these high level things that will be shared in the final evaluation report. This is just really high level sample of some of the work that's being done to address this priority area and help to advance health equity. And so the state has its own process measures that they're working towards to make progress on these immunizations related accountability metrics. OHA's process measures are multi-year and are continuing to be worked on. And so some of these measures and the things that are being done are developing and maintaining data for immunizations, such as having data dashboards available for 2-year-old and influenza immunization rates. They're currently up and running, and I think one of them may have already been shared in the chat if I saw correctly. Um, Another activity is implementing the immunization quality improvement for providers program, providing data to CCOs and partnering with them for quality improvement program implementation, and assuring the state's vaccine supply and monitoring Oregon's vaccine finance model to ensure sustainability and equity. So those are some of the actions being taken at the state level. You can see they're a little bit different than what LPHAs are doing. We each have our own role in this process. So I'm going to pass it over to Kazuma to talk about how we integrate these two domains together.
Thanks, Thomas. Okay, so when you think about the two domains and what you heard, this is very high level, but when we think about what were the challenges across both domains, you'll see in the orange at the bottom that the similar challenges across both domains were a limited workforce capacity, uncertainty in a sustainable plan and funding, and all of this is well before um, November of 24. And the coordination, needs for greater coordination among partners and needs for clarity among understanding what partners' contributions are. So those are some of the challenges across both domains that we heard from the evaluation. We'll go to the next slide. This is the accountability metrics framework that I think you may have seen before, but the focus that has been the area of priority right now is what you see in the far right on the orange. That is OHA and local public health authority accountability. That's what we've been focused on in this reporting. And I think in the future, it's going to go more for the collective responsibility and partner contributions across sectors and partners to help all of us as a system make progress towards these metrics. Let's go to the next slide. Overall, I think through this domain, we have seen advancements in how we measure effectiveness of our public health system, our governmental public health system in this case, through advancing measures of effectiveness through increased reach. And I'm going to give some examples of each of these. So increased reach to target populations, and some of these Thomas has already talked about, but administering and coordinating vaccination to homebound individuals and long-term care facilities, administering mobile vaccination clinics and vaccination events, providing syphilis testing in local jails and juvenile detention centers, and increasing access to cooling centers and cleaner air spaces for certain priority populations. In terms of dissemination of information, products, or evidence-based practices, we see this through our work with you all and some of others and partners to develop culturally specific communication materials and provide culturally appropriate education, providing subject matter expertise on policy development, implementation, and advocacy in all these three priority areas, sharing statewide immunization, syphilis, and health impacts of climate data through publicly available data dashboards to our partners. In terms of quality enhancement to services or programs, we see translation of materials, providing technical assistance to non-traditional providers and healthcare providers and long-term care facility staff to help increase vaccination rates and support individuals with increased exposure to extreme heat and wildfire smoke, such as providing hats, sunscreen, masks to farm workers, medically fragile residents, and houseless populations. Our increase in the quality enhancement of our data systems means developing and maintaining our data dashboards by county and race ethnicity by all three of those programmatic areas that you just heard about, as well as eventually doing the work of core public health to increase preventive behaviors. All of that leads to that. And those true core public health capabilities, be able to track the percent of congenital syphilis cases averted statewide, track percent of prenatal care providers who report screening of all pregnant patients early in the third trimester, and track immunization rates, as well as track emergency department and urgent care visits due to heat. All of that hopefully is leading to a decreased incidence or prevalence of the diseases that we have shared with those priority areas. So we'll go to the next slide. And want to go back and go back to the questions that we raised at the beginning of our presentation and have a chance for some of an exercise and just have a discussion with you all about what resonated, what didn't with what you heard, and what actions would you like to see come out of this work. So I'm going to turn it over to Thomas, who is going to facilitate a little opportunity for you all to either type in some comments or just share verbally. So Thomas?
Yeah, thank you. I am clicking some buttons here real quick to make sure that the annotation works. So for those who may or may not be familiar with Zoom's annotation tool, you could follow the instructions here on the screen. There's three dots at the top of the shared screen. It'll probably say Thomas Packabush's screen, and there's three little dots next to it. You can click on that and select the annotate button, and it'll allow you to draw on the shared screen. Um, or you can hover over the slides that I'm sharing, and there'll be a little green pencil down at the bottom that looks like this, that you'll be able to click on and either type in a response on the screen, draw it. I would recommend typing because the drawing can get complicated. And you can also add little check marks if you agree with what someone else has said. We also welcome you to just unmute or raise your hand and share your comments or put them in the chat, whichever way is best for you to communicate. We recommend. I'll also note that the annotation is anonymous. It won't show your names to us or anyone else. So if that encourages your participation, just know that you're safe. So our first question here is what does and does not resonate with you? Things that do resonate, you could put on that left side of the screen, and those that do not resonate, you could put on the right, or just unmute, put things in the chat. We'll be reading off answers as they're shared either in the chat or on the screen.
And as folks are thinking about anything they want to share, I just wanted to respond to Rebecca with your comment. I am not an expert or in the program for immunizations. I don't know if Steve or Andrew or Sarah is here who wouldn't want to respond to that. But I do know our immunization program staff are the one that determine the data sources for what should be used. So just to say that I'm not a program expert in the immunization area, tracking that. But Steve, I would, if there's anything you wanted to add to that, Steve, I'll just defer to you.
Yeah, hi everyone. I'm Stephen Fiala, he, him pronouns, public health modernization lead with the public health division. And I'm not going to be able to offer much more than Kasuma. As Kasuma said, the program experts, in this case from Oregon Immunizations Program, decide on the data source that we'll use for kind of ongoing tracking of these metrics. But happy to, I already copy and pasted your comment, Rebecca, and happy to bring that back to the team and discuss this particular issue of kind of cross-border immunizations. Um, yeah, but that's I think all I can offer today, and I appreciate you commenting on this so we can bring it back to the team.
Thanks, Steve. I'll go ahead and read off some of the things that have resonated with folks so far. And don't worry if stuff overlaps. I can move it around. Um, so the first comment that we have here is appreciated the priority area activity ideas that Kazuma had shared. I now realize we have been doing a lot more that we did not identify for climate work, for example. I think clarification on what is being expected from the state is a crucial piece. More in-depth training for LPHAs on what public health modernization is and what we should be doing. And evaluation seems to have captured very clear feedback for OHA development. I would just note for that first comment, even the things that we do share are limited to what's reported. So we know that there's a lot of great work being done beyond everything that will be in the report as well. This is just what was reported on in our evaluation, and we really want to demonstrate the value of this work.
Hey, Thomas, I see some folks are already seeing the way to like upvote or be like, yes, I agree. Would you mind showing or letting people know on the doc where they can do a check mark or a heart? I see that people are trying to use that. I just want to make sure folks know.
Yeah, I don't know, can you see my little doc on the screen now or no? Do you just see my cursor moving around?
I see the cursor. I know I see a doc on my screen.
Gotcha.
So yeah, so if you
Yeah.
look on the left-hand side, it should be the fourth symbol down the list. You can choose a star, a heart, a check mark. I think there's also a little plus sign. So I just wanted to let folks know they can engage that way as well if that didn't seem obvious.
Absolutely. Yeah, thank you. I think they're called stamps. And you can select any of those icons to help show that things you agree or do not agree with what's being said, whether it resonates or not. We do have one more slide to share and to have everyone interact with and get your feedback on. So I am going to, oh, we got one more. Age is not listed in inequity categories and it needs to be there. Older adults are at great disadvantage as our system are not updated to support this large and growing population. Yeah, thank you for that comment. Okay, I'm going
I
to,
just want to, I want to just clear, I want to make sure I understand correctly. So in the inequity categories on our slide, is that right? Did we not have? I just want to make sure because I know age is part of the immunization, 65 and older, and we have age for 2-year-old for immunizations. Age is captured through the immunization work and the congenital syphilis work. But I'm just not sure if I was that in our slide, Thomas, because I want to make sure it's corrected if it's not there.
yeah, I'm going back and looking
Okay,
at it real
thank you
quick.
for making sure that, thanks for calling that out, whoever did, and we'll make sure that that is captured, because it is captured in the work for sure.
Yeah, when I was reading the slide about OHA's goal of eliminating health inequities is when I
Uh-huh.
listed off those variety of factors, and
Oh,
age was included in there. So
okay.
just to clarify, yeah, some of the things that were in there were race, ethnicity, language, disability, immigration status, age, gender, gender identity, sexual orientation, geography, or social class. Um,
We'll go back and double check. Okay, thank you, Thomas, for reading that out. I just wanted
yeah.
to make sure we understood the comment very quickly. Thank you. Whoever brought that up as well.
Okay. I am going to clear this away real quick and oops, and go to our next slide, which is what actions would you like to see come out of this work? Once again, you're welcome to annotate, use the chat, unmute. But based on the things that you've heard today, based on what resonated, based on the recommendations you heard that participants of our focus groups provided, what actions would you like to see come out of this work for modernization moving forward? We have a comment here. I would like to see more communication about public health modernization success stories and case studies. It would be helpful to see what other people use funding for that the state looks at and can affirm, yes, these are the types of projects we're hoping to see when we allocated modernization funds.
Thank you. One thing we didn't have time to share today due to our time was we did do, we mentioned in the methods for the second domain was to do we did 2 in-depth case studies, one with Lincoln County and one with Multnomah County. Multnomah County was focused on the climate impacts of extreme heat and mitigation and all the work they're doing related to that. And the Lincoln County one is focused on communicable disease and the work that they're doing. So we're really looking forward to sharing that with you all as well as part of this evaluation, but we just didn't have time to really share even high level with that to be able to allow for some discussion. So, but it's helpful to hear what you would like to see more of. Should we go to our next and final slide on next steps?
Yeah, absolutely.
Okay.
Let me clear this off.
Oh,
Cool.
we got another one.
Related to case studies, rural case studies for counties with populations under 15 or 20K would be really helpful. Yeah, thank you
Thank you.
for sharing that. Okay. I'm gonna go ahead and uh, disable annotation now so we can continue on with our slides and more text won't pop up on them.
Thanks, Thomas. So our next steps are we have been presenting for the last month or so, a couple months, on these evaluation results to different audiences, whether that be local public health authorities, the state, you all, and we're working now on our report that we're hoping to have in the next couple months that'll flesh out all of these things more in detail and be able to share that with you. That includes those 2 case studies as well. And so if you wanted to say that if you have questions about public health modernization or want to learn more about it, Stephen Fiala is our point of contact in the public health division. Stephen answered a couple questions here already, but we just want to know that he is your point of contact for other questions or if you wanted to learn more about it. Steve, I don't know if you wanted to share anything at that point. I didn't want me to put you on the spot, but oh, thanks. Any other questions? Oh, and thanks, Thomas. This is our PDS evaluation team. But if there's any other questions, maybe we can stop sharing the slides and just open it up for any other feedback or questions at this time. And feel free to reach out to Thomas or I separately as well if you have questions also. But thank you for the opportunity to share this work with you.
Yes, thank you, Kasuma. Thank you, Thomas, and Stephen. Thank you also for maybe you weren't aware that you were going to be a part of the presentation, but thank you for being here to answer questions. For folks, as you are maybe thinking of anything you would like to ask as we wind down here towards the end of the hour, friendly reminder, you all will get a follow-up email with the recording, which should be good this time. I apologize that we had technical difficulties last month. The slides that were shared today, and then the contact information for the other three folks that are on camera right now with me, Kasuma, Thomas, and Stephen, for follow-up questions. I will also do my best to locate the links to some of the pages that were shared where information was being gathered and collect those ones that I could find in real time in the chat that I shared as well. So please make sure that you reach out if you have follow-up questions. And as far as this presentation goes, you all are welcome to take your 5 minutes back and go about your day doing your good work. Thank you.